Welcome to this Step 2 clinical knowledge review on vasculitis test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for vasculitis, including giant cell arteritis, polymyalgia rheumatica, Takayasu arteritis, polyarteritis nodosa, and the vasculitides associated with anti-neutrophil cytoplasmic antibodies. The goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the rheumatology and immunology sections of first aid in your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn to recognize high-yield question stems for vasculitis on board exams, including large vessel, medium vessel, and small vessel patterns. Second, we will apply test-taking strategies for giant cell arteritis, Takayasu arteritis, polyarteritis nodosa, and anti-neutrophil cytoplasmic antibody-associated vasculitis questions. Third, we will master the next best step question format for diagnosis and treatment of common vasculitides. Before we dive in, make sure you have reviewed the rheumatology and immunology sections of first aid, your question bank, and pathoma. This video focuses on how to apply that knowledge strategically on exam day. The first strategy for vasculitis questions is to classify by vessel size. This is your most important branch point. When you see a vasculitis question stem, immediately ask yourself whether this is a large vessel, medium vessel, or small vessel process. For large vessel vasculitis, look for temporal headache, jaw claudication, and vision changes in an elderly patient, which points to giant cell arteritis. If you see absent pulses and blood pressure discrepancies between arms in a young woman, think Takayasu arteritis. For medium vessel disease, hepatitis B association, mesenteric angiogram findings, and lung-sparing point to polyarteritis nodosa. For small vessel disease, hemoptysis, sinusitis, glomerulonephritis, and positive anti-neutrophil cytoplasmic antibodies point to the small vessel vasculitides. The boards love testing whether you can make this distinction quickly. Strategy 2 focuses on recognizing giant cell arteritis and its close association with polymyalgia rheumatica. For giant cell arteritis, the classic question stem gives you an older patient, usually over 50 years old, with a new-onset temporal headache, jaw claudication, scalp tenderness, and visual disturbances. The erythrocyte sedimentation rate will be markedly elevated. The most feared complication tested on boards is irreversible vision loss. So when the question mentions vision changes, you need to act urgently. For polymyalgia rheumatica, look for bilateral shoulder and hip girdle stiffness and pain, morning stiffness lasting over 1 hour, and elevated inflammatory markers in an older adult. The critical board concept is that polymyalgia rheumatica often coexists with giant cell arteritis. If a patient with polymyalgia rheumatica develops a headache or visual symptoms, you must evaluate for giant cell arteritis immediately. This overlap is a favorite board question. Let us review the high-yield stem patterns for each major vasculitis. For giant cell arteritis, you will see an older patient with a new temporal headache, jaw claudication, elevated erythrocyte sedimentation rate, and visual complaints. The gold standard diagnosis is temporal artery biopsy, but the key board rule is to start steroids immediately without waiting for biopsy results. For Takayasu arteritis, the classic stem gives you a young woman under 40 with arm claudication, blood pressure discrepancy between arms, absent or diminished pulses, and constitutional symptoms. Imaging will show thickening of the aorta and its major branches. For polyarteritis nodosa, look for a middle-aged patient with hepatitis B, fever, weight loss, abdominal pain, skin nodules, and kidney involvement that is not glomerulonephritis. Mesenteric angiography showing microaneurysms is the classic diagnostic finding, and the lungs are characteristically spared. Remember, lung sparing is what separates polyarteritis nodosa from the small vessel vasculitides. Here is our first practice question. A 72-year-old woman presents with a 3-week history of new onset right-sided headache and jaw pain when chewing. She also reports blurred vision in her right eye that began yesterday. Her erythrocyte sedimentation rate is 95 millimeters per hour. What is the most appropriate next step in management? Take a moment to think about this one. Look at the age, the headache location, the jaw claudication, the visual symptoms, and the elevated inflammatory markers. What pattern does this fit? Let us walk through this answer step by step. Step 1. Spot the pattern. We have an elderly woman with a new temporal headache, jaw claudication, vision changes, and a markedly elevated erythrocyte sedimentation rate. This is textbook giant cell arteritis. Step 2. Apply the rule. The board rule you must memorize is that when you suspect giant cell arteritis and the patient has visual symptoms, you start high-dose glucocorticoids immediately. You do not wait for the biopsy. Delaying treatment risks permanent blindness, and the boards want to see that you know this urgency. Step 3. Eliminate the wrong answers. Choice A, temporal artery biopsy, is the gold standard diagnostic test, but it should not delay treatment when vision is threatened. The biopsy can still be positive even after several days of steroid therapy. Choice C, non-steroidal anti-inflammatory drugs, are completely insufficient for treating giant cell arteritis. Choice D, magnetic resonance angiography, is more useful for large vessel vasculitis like Takayasu, not for the immediate management of suspected giant cell arteritis with threatened vision. The correct answer is B, high-dose glucocorticoids. Here is our second practice question. A 28-year-old woman presents with a 2-month history of fatigue, low-grade fevers, and pain in both arms with activity. On exam, her right radial pulse is absent and her left radial pulse is weak. Blood pressure in the right arm is 80/50 and in the left arm is 130/85. What is the most likely diagnosis? Again, focus on the demographics and the physical exam findings. What stands out about this patient? Let us walk through this answer. First, read the question carefully. We have a young woman under 40 with constitutional symptoms including fatigue and low-grade fevers, arm claudication, absent pulses, and a significant blood pressure discrepancy between arms. This is classic Takayasu arteritis, which is sometimes called pulseless disease. Now, why does Takayasu arteritis win over the other choices? Choice A, giant cell arteritis, affects patients over 50 years old. This patient is 28, making giant cell arteritis far less likely. Choice B, polyarteritis nodosa, is a medium vessel disease that affects organs like the kidneys, gut, and skin. It does not cause pulse deficits in the extremities. Choice D, granulomatosis with polyangiitis, is a small vessel disease that classically presents with sinus, lung, and kidney involvement, not large vessel occlusion with absent pulses. Takayasu arteritis targets the aorta and its major branches, causing stenosis that leads to the pulse deficits and blood pressure discrepancy we see here. The correct answer is C, Takayasu arteritis. This slide covers the critical distinction between polyarteritis nodosa and the small vessel vasculitides. For polyarteritis nodosa, remember the hepatitis B association, medium vessel involvement causing kidney damage without glomerulonephritis, mesenteric ischemia, skin nodules, and peripheral neuropathy. A huge test-taking pearl is that polyarteritis nodosa characteristically spares the lungs. The anti-neutrophil cytoplasmic antibodies are negative, and the classic diagnostic study is mesenteric angiography showing microaneurysms. For the small vessel vasculitides, these are the anti-neutrophil cytoplasmic antibody-associated conditions: granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. These involve small vessels and commonly affect both the lungs and kidneys with glomerulonephritis. The boards love asking about this lung-kidney connection. If you see lung and kidney involvement together, think small vessel vasculitis. If the lungs are spared, think polyarteritis nodosa. Here is practice question 3. A 45-year-old man with chronic hepatitis B presents with 3 weeks of fever, weight loss, diffuse abdominal pain, and a new foot drop. Laboratory studies show elevated creatinine and an active urine sediment without red blood cell casts. Mesenteric angiography shows multiple microaneurysms. What is the most likely diagnosis? Think about the hepatitis B association, the angiographic findings, and critically, what is missing from the urine sediment. Let us walk through this answer. Step 1. Spot the classic pattern. We have hepatitis B, constitutional symptoms, abdominal pain suggesting mesenteric ischemia, foot drop indicating mononeuritis multiplex, elevated creatinine without red blood cell casts meaning no glomerulonephritis, and microaneurysms on mesenteric angiography. Every one of these findings is a classic feature of polyarteritis nodosa. Step 2. Know the key distinction. Choice A. Microscopic polyangiitis is a small vessel vasculitis that causes glomerulonephritis with red blood cell casts. This patient does not have casts, which is a critical negative finding. Choice C. Granulomatosis with polyangiitis involves the sinuses, lungs, and kidneys with glomerulonephritis, none of which are described here. Choice D. Eosinophilic granulomatosis with polyangiitis is associated with asthma and eosinophilia, which are not present. The hepatitis B association, the absence of glomerulonephritis, the lung sparing, and the microaneurysms all point to polyarteritis nodosa. The correct answer is B. This is an extremely high-yield test-taking pearl about anti-neutrophil cytoplasmic antibody associations. The cytoplasmic staining pattern targets proteinase 3 and is strongly associated with granulomatosis with polyangiitis. The classic triad for granulomatosis with polyangiitis is upper airway disease with sinusitis and saddle nose deformity, pulmonary involvement with nodules or hemorrhage, and rapidly progressive glomerulonephritis. If you see sinuses plus lungs plus kidneys on a board question, think cytoplasmic pattern and granulomatosis with polyangiitis. The perinuclear staining pattern targets myeloperoxidase and is associated with microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis. Microscopic polyangiitis presents with pulmonary renal syndrome, but without upper airway involvement, which distinguishes it from granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis presents with the unique combination of asthma, eosinophilia, and vasculitis. If you see asthma plus vasculitis, that is eosinophilic granulomatosis with polyangiitis until proven otherwise. These antibody patterns and clinical associations come up repeatedly on the boards. That wraps up our vasculitis test-taking strategies for Step 2. To summarize the key takeaways, always classify vasculitis by vessel size first. For giant cell arteritis, remember the urgency of treating vision symptoms with immediate glucocorticoids. For Takayasu arteritis, look for the young woman with absent pulses and blood pressure discrepancies. For polyarteritis nodosa, remember the hepatitis B association, lung sparing, and negative anti-neutrophil cytoplasmic antibodies. For the small vessel vasculitides, know the antibody staining patterns and their associated diseases. Review the rheumatology and immunology chapters in first aid and your question bank, and focus on vasculitis classification by vessel size, diagnostic workups, and treatment algorithms. Visit roadmap-to-residency.com for expert tutors and residency advisors who can help you prepare for boards and the match. Please like and subscribe for more board review content. Good luck on your exam, you have got this.